Hi, folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by SpeechTherapyPD.com. I am your host on this nerd venture, Michelle Dawson, MS, CCC-SLP, CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention, right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts,
to break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP, CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. Hi, my name is Michelle Linwood Dawson, and these are my financial disclosures. I am the author of Chasing the Swallow, Truth, Science, Hope for Pediatric Feeding and Swallowing Disorders, for which I receive royalties from the sale of. I receive compensation from SpeechTherapyPD.com for CEUs associated with the book, for this podcast, First Bite, as well as for numerous other presentations. I received compensation from PESI for one course that I have with them. I receive an annual salary from Wolf Speech Therapy Plus LLC, as well as in my capacity as adjunct professor at North Carolina Central University. And I receive profits from the sales of First Bite Boutique sweatshirts and t-shirts that Erin and I design that is not affiliated with First Bite, the podcast, which is sponsored by SpeechTherapyPD.com. My non-financial disclosures. I am topic chair for the Pediatric Feeding and Swallowing Disorders for ASHA for the 2024-2023 convention. I am the chair of the special interest group, or co-chair of the special interest group for pediatric feeding disorders and dysphagia for the Speech Language Hearing Association of Virginia. I am a convention committee member for the Speech Language Hearing Association of Virginia. I am a member of the Speech Language Hearing Association of Virginia. I'm a board of trustee member with the Communication Disorder Foundation of Virginia. I'm a former treasurer with the Council of State Association Presidents, past president of the South Carolina Speech Language Hearing Association. I am a member of ASHA, ASHA SIG 10, ASHA SIG 13, SCISHA, Dysphagia Research Society, National Foundation of Swallowing Disorders, and the National Black Association of Speech, Language, and Hearing.
Okay. My name's Erin Forward, and here are my disclosures. Financial disclosures. I receive a salary from Cincinnati Children's Hospital Medical Center. I am the owner of Forward Education LLC, where I do courses. I receive royalties from Speech Therapy PD for this podcast, First Bite, and other presentations as well. I am also a owner of First Bite Boutique with Michelle Dawson and receive compensation for that, which is also not associated with First Bite podcast, sponsored by Speech Therapy PD. Non-financial disclosures. I am a contributor for the book Chasing the Swallow by Michelle Dawson. I am a member of the South Carolina Coalition for DIR Floor Time. I am a member of ASHA and SIG 13, as well as Dysphagia Outreach Project and Feeding Matters. And I think that's it.
Huzzah! Thanks, y'all. Thanks for sticking around to listen all the way through to the disclosures. Yay!
The views and opinions expressed in today's podcast do not reflect the organizations associated with the speakers and are their views and opinions solely.
Thank you so much for joining us today for one heck of an interesting talk. Y'all, we are in for a hoot. We have possibly one of the most joyful souls I've ever come across. And good Lord, we met at CSAP, the Council of State Association Presidents. I honest to goodness don't remember how long ago. Was that like 6 years ago? 5 years ago?
Yeah, probably 2017, 2018.
So 7-6. It's been a minute. It was prior to having this much gray, but there, y'all, we have none other than Miss Kara Jones, CCC-SLP CBIS. She is a certified brain injury specialist. And her and I met. She's past president of Georgia to my past president of South Carolina. And I always laugh because scissus sounds like a scab and gaseous sounds like a wound. So we got the South band-aided and covered. But our paths have lovingly crossed over the years between CSAP conventions. I've had the joy of going out to Georgia to present a few times. And y'all, if you're looking for one heck of a fantastic convention, Georgia puts on a spectacular speech pathology conversation. It's in February normally. Yeah, and the last couple times it's been at Athens. Does it move around?
It does move around, and it's at the very end of February, I think the first weekend of March. And this year it's in the city of Atlanta.
Oh, yes. I have gone so many times and I never make it to the Coca-Cola one. So that's next time we go back, that's on my to-do list. And I really don't like soda, but I heard you get to like taste test them. Okay, this was not the purpose of today, but we digress nonetheless. But y'all, I know she regularly presents at Georgia. So if you're so inspired, either she'll be there to support or might even be presenting in 2025. But y'all are in for a treat. Kara leads with kindness and compassion for her colleagues and for her patients. And she is an adult clinician and a mighty powerful one at that, which I can hear some people being like, but this is predominantly a peds podcast. Yes, but once upon a time, this is scary. I was an adult therapist. Can't imagine that. And I know that a lot of us out there, PRN, or maybe we're going from the peds world into the adult world, or you're a student and you're trying to discern where your calling is. Either way, the reality is the individuals that we come across and we work with, a lot of them will have brain injuries, which is why we're there. And so when she made her Instagram post celebrating this endeavor, I was like, oh my God, we haven't covered this. We have to have it on. So without further ado, longest intro ever, but I like fangirl the hell out of you and think you're amazing. Hi, thank you so much for coming on.
Thank you for having me. That was a wonderful introduction. I feel super pumped up.
Okay, take us from the top. How did you become a speech therapist and wind into the world of adults and leadership and advocacy?
Okay, so when I was younger, my cousins got home health speech therapy, early intervention, and preschool therapy at their house. And I would often spend some days at my cousin's house with my aunt, and I would get to see Miss Kim and everything Miss Kim did. And I was like, yep, that's what I want to do. I want to be Miss Kim when I grow up. Then fast forward to graduate school, I was doing my early intervention placement, and I was like, maybe this is not exactly what I want to do. And it made me rethink, but I did an adult placement that I really enjoyed. And I didn't really think that's the path I wanted to take until I did my internship. After I graduated, I did actually still end up working with peds, but I worked in the schools for a couple of years.
I didn't know that.
Yeah, so I've worked in the schools in California, Wisconsin, and Georgia.
Were you on a travel contract?
I was traveling with my husband, so we were just moving around to different agencies. But then once I was in Georgia, I ended up wanting to spend, actually when I started in Wisconsin, I started working with adults and hospitals, and I just slowly migrated to full-time hospital work from school-based work. And so I've been at my same hospital for 10 years now, and I've done inpatient
Wow.
rehab, acute care, and now I'm in outpatient rehab. And so the
Nice.
outpatient rehab is primarily neuro, although we do get voice and we do have a head and neck cancer clinic that we're building.
Wait, what part of Georgia are you in?
So I'm in the suburbs of Georgia. So Roswell is where I work, and I live in Marietta.
Okay. Okay.
Mhm.
I'm like, all I know is Atlanta and Athens. And beyond that, one of my girlfriends, my husband's old work wife, we called Miss Wendy my husband's work wife. Miss Wendy lives just outside of Augusta, but like a little bit more north and rural. So but nobody's heard of her town. So she just goes, just go with Augusta. So that's my extent of my knowledge. It's great. Went to Mississippi a couple weeks ago and wasn't sure if I was east or west of the Mississippi. And my son was like, Mom, you really need to study a map before you go places. I was like, yes, sir. Noted. Okay. General curiosity. How did you prep and ready your brain and your skill set to go from peds to adults? Because I started in the schools as a speech teacher, but when I went into the hospital for adults, it was overwhelming and I felt horribly unprepared. So if somebody's listening and wants to contemplate that, what all did you do personally?
I was fortunate enough to jump into the adult world the year that I got my C's, so that second year of working. And I was fortunate enough to get a mentor at the company I was working at.
Amazing.
So that was very helpful. And then, in addition to mentorship, it's been a lot of continuing education, getting to know people, using the internet to reach out to people, take courses. It's been a lot of that, but I've had mentors along the way. I'm a big proponent of there's no speech therapy job that's easier or harder than another, and there's no
Yes.
setting that is inherently easier or harder than another. Being
Yes.
a medical SLP can be just as challenging as being a school-based SLP. It's just a different challenge. And so I get a little angry at the gatekeeping in the medical SLP community, saying you don't have the knowledge and we don't have the time to give you the knowledge. But then there's places that have all these staff shortages because we can't find therapists who are properly trained, but we're not giving them the opportunity to train. So that's one of
Yeah.
my soapboxes that if
No.
someone wants to learn, let's, help each other and help each other learn.
Yes. It's the same in the PFD world. There's so much gatekeeping in the PFD world or pediatric feeding disorders, but it's a disservice because we need allocated time to be able to pour in and do mentorship. And if we don't carve out the time to make that, then nobody is set for success. So, folks, if you're listening and you have yet to volunteer as a clinical supervisor for a graduate student or an undergrad, if that's appropriate for your work setting, or a CF mentor, please, you're never going to get paid back for it financially, but you're working to resolve the gatekeeping, right? Yes.
Right.
We say that, but also in the back of my mind, because of ADD, I'm thinking about the fact that we're going to put in a summer gate one day, like over between our trees. So I'm like thinking of, oh, what kind of gate should we put in between the trees? It's fine.
I think the other part of gatekeeping too is you need to talk to your management and your
Yes.
supervisors about the limitations in speech therapy training, even if you are somebody that did their C's, their CF with adults, but maybe in skilled nursing, you might not still have the skill set to work in a hospital.
Yep.
And it's important to make it clear and make it very transparent that mentorship is expected
Yes.
and it's just part of doing business in speech therapy.
Yes, it is. And that's part. Yes, it is for every setting. And whenever you have a change in setting, you have to know the rhythm and rate of the new site. What are their spoken policies versus unspoken policies? The social rules with which we adhere. That's what I tell my son. You got to figure out what are the social rules that you adhere to, because different places have different rhythms. Oh my gosh, y'all can't see it, but her eyes are like, yup.
Yeah, I totally get it.
I laugh. I worked at a skilled nursing facility for 6 weeks. For 2 weeks, and then I gave my 4-week resignation. So like that was, but it was not for me. My grandparents raised me, and it was too hard on my heart. And that's how I knew that this is not for me. It is It is what it is. But okay, so we went down a very long, windy road, and as such it is. But you have obtained this amazing certified brain injury specialist license or certification. And I don't fully understand what it is, what it stands for, and what all goes into it. So please describe.
Okay, so CBIS are some letters I get to put after my CCCs, and it stands for Certified Brain Injury Specialist. And it's not a certification through ASHA, it's a certification through the Brain Injury Association of America. So that's the BIAUSA or BIAUSA. And so what this is a certification that anybody that has a high school diploma, some sort of license in the area of working with brain injury. So you might be a licensed nurse, you might be a licensed caseworker, you might be a licensed occupational therapist, physical therapist, or speech therapist. But if you can demonstrate that you've had 500 contact hours with someone with a brain injury or people with a brain injury, that does not include volunteering, but it can include your academic internship, then you can have the opportunity to sit for this exam and have this certification. And the reasoning behind this certification is it makes you, the practitioner, highly sought after in the field. But I also think the idea behind it is that you can't be a practitioner of people with brain injuries and only know your very narrow speech therapy focus. This certification opens you up to learning about what does case management do? What are legal things? What are financial limitations? What are happening with their neuroanatomy? And what does PT do and what does OT do? And having that broader knowledge of a brain injury, I think can really help you be a better clinician and better advocate for your patients.
You just described interprofessional practice. Like
Yep.
that's like the active interprofessional education, which is learning about what the different specialists do to then improve your action of interprofessional practice of working with those professions. But if we understand where they're coming from, that's huge. Now, I got to be honest, all the CBISers that I know, of which there are two, you and Renee, because y'all, this is hard. You're both adult people. So it skews my brain to think when we're looking at brain injuries, are y'all talking about like neurodegenerative diseases, Parkinson's or ALS, or what kind of brain injuries? And that's, I'm in the world of swallow. So this is a very different, well, actually, it's not that different because normally it's neuro driven, but what kind of brain injuries are y'all looking at?
So it can be both traumatic and acquired brain injuries. And so for thinking about the PEDS world, unfortunately, there's a very high rate of children with brain injuries due to physical abuse or due to sports injuries like on the playground. And so children and young babies can get brain injuries just as frequently as adolescents and teens. So that's important to think about. But then the other side of this traumatic brain injury is also acquired brain injury. So that might be something like a stroke, which we know,
I see that
unfortunately,
all the time.
children can get strokes, unfortunately. And then also things like brain tumors.
I have, over the course of my career, worked with numerous individuals that have dysgenesis or agenesis of the corpus callosum. So acquired congenital conditions, also very interesting and unique presentations. If you've seen one individual with agenesis, it's not necessarily indicative of another individual with agenesis because it's very interesting to me how different that can present. Yeah.
But so an acquired brain injury or traumatic brain injury is not going to be something that's congenital. So it's not going to be something that develops over time or something like Parkinson's disease that's a degenerative disease. It's more of something like an insult to the brain.
What do you see the most of right now in your setting, like in the outpatient adult world?
Strokes, but then I do see a good proportion of traumatic brain injuries, especially young adults from motor vehicle collisions, things like that. And then I do see some brain tumors.
That's y'all, this is the stuff where this is why I keep a tissue in my sweatshirt at work in my wrist. And I know I have a thimble collection upstairs and I'm secretly an 80-year-old woman and I always have a teacup, but It's moments like that where when a mom comes in and starts sharing their walk, or the grandparents who are raising the tiny human that I'm working with, that talking about brain injuries is hard because the etiology versus the healing trajectory can be so different. Yeah.
Yeah. And I feel like as a speech therapist, I felt like I was really well prepared to work with strokes, but working with young adults with brain injuries was definitely something that inspired me to go get this brain injury specialist to push myself a little further to help understand how I can help this specific population.
Okay. All right. So I want to follow-up question to the CBIS, like what the cert looks like, but then I want to tiptoe into the TBI world because that's not a population that I work with, and I'm really curious as to. I've seen little ones with shaken baby syndrome, which is now non-accidental trauma in the literature. We no longer call it shaken baby. The terminology has changed, but from a true hit on a field or in a car accident, motor vehicle accident. Is that how you say that? Is that the correct terminology? Motor vehicle
Yeah.
accident? Yeah.
Yeah. Or MVC, motor vehicle collision,
Yeah.
either one.
Okay. See, make me cool. Not my world. I'm learning
Yeah.
my semantic knowledge is growing. What were the steps that you took to get your CBIS?
Okay, so the first thing you have to do is you have to apply to even sit for the exam. So you need to fill out an application where it's basically filling out a resume. This is my certification level, right? I'm a licensed speech therapist. This is where I've worked, just some basic demographic information. And then I needed my employer to verify that I've had that set number of hours, the 500 hours. But if that 500 hours can really add up when you think about brain injury includes strokes, and brain injuries include TBIs, and brain injuries include other
Etiologies.
etiologies like brain tumors and things like that, or any kind of gunshot wounds too. And yeah, so when I did the math, I was able to say, yeah, I've done about this many hours, and it's just a form for my employer to sign. So it wasn't like I needed like a very strict record the way that we need to have when we apply for our CCCs, for example.
Yes.
So that wasn't too hard to do. Once they look over everything and they approve you to sit for the test, now it's time to study for the test. And there's some different routes you can take. You can either sign up to do a training with a CBIS trainer, and so you can do that individually, or you can see if your workplace will let you do it as a group. Or you can get the book and do some self study. And the application fee is about $300, but it could be less if you're in a group.
What route did you take?
I signed up with a trainer, and I was very happy with that. So the trainer I sat with, her name is Tracy, and she has a Instagram page that you can find her at TBI Med SLP. And Tracy was really great because she sat down with me for a couple hours each week for a month and just went over all the content with me. And it was a lot of content. Like, it's a lot. And I do feel like I learned a lot about brain injuries in school, or I learned a lot about neuroanatomy in school, but this was way, way more content and information.
I legit don't think I learned. Okay, Carol, if you're listening, I know I took your neurocog class a very long time ago, but ma'am, it is gone. It's 20 years later, it's gone. But yeah, but also science has changed a lot in 20 years. So I'm sure what we learned back then is slightly different than today. So there's that factor as well. But was there anything that you were like, oh my God, that makes so much sense? How did I not know that when you were studying?
That was the way it was for a lot of things. I think a lot of it was a lot of the content that's part of the certification is understanding how difficult it is for someone to live with a brain injury in the United States, and all the terrible
I had no idea.
repercussions there are in between homelessness and being jailed and not being able to work and having repeat injuries and having mental health impairments because of it. And I think I understood that, but once it like sat down and taught me all those things, I was like, oh wow, this makes so much more sense now. But as who's helping an individual return to work after a TBI, this makes their ability to return to work so much bigger, because if they can't get back to work, that's when the homelessness comes on. That's when all these other problems happen.
Cycles. Yeah.
Yeah, and substance abuse too, right? It's can you help these people when they first come to you after their brain injury and help them down the right path, but sometimes it's a financial thing. And what I learned from studying to be a CBIS is that pretty much everyone is unprepared for having to deal with a brain injury. And they said like the stat was like 5% of individuals are prepared for the long-term financial strain of having a brain injury, which is very sad.
I think about on the tiny human side, the financial component of taking on the lifelong responsibility of having a child with a disability or a difference, however an individual or caregiver chooses to look at it, and the inherent barriers of getting access to care for Social Security income, for getting Medicaid or Medicare to approve. And okay, we watched last week tonight with John Oliver. Love this show. A couple of weeks ago, y'all, he did an episode dedicated truly just to disability in America. And I'm going to cry. I have never seen my husband so hurt as I did when he watched that, because this is his brother, right? This is his brother who will come live with us, like Uncle Matthew. My brother-in-law has microcephaly as primary etiology, a cortical vision impairment, autism spectrum disorder, and intellectual disability. He is phenomenal. Uncle Matthew is a hoot and a half, and he's feisty, and he's getting feistier in his old age. He's 47, and he's got so many little gray hairs in his eyebrows now and they're just as unruly as my husband's. It makes me giggle. I want to trim them. But Matthew, one of the reasons we moved back to Virginia, and we're so grateful that my husband's career brought us back to our home state, is because had he gone from Virginia to South Carolina, he would have lost his Medicaid and Medicare waiver and all of his waivers because he transitioned. He would have had to go on our insurances and all of these things, which he has congenital brain malformations. He has a cortical vision impairment. His eyes are fine. His optic nerve is essentially non-existent, and his occipital lobe is greatly compromised. Again, it was congenital. And this is a lifelong factor that his parents have had to work into retirement plans and trust funds and all of this. And then now that we're back, it's how do we put a wing on the house that meets his aging in place needs, which are very unique. But it goes back to his brain. But I say all this because John Oliver's episode on disability in America was so powerful. So y'all, yes, he makes very inappropriate political comments, so don't shoot the messenger, but my family loves him. Yes.
But I feel like that episode too was a call to action to all of us to really not just let this continue to happen. Like one of the big things on that episode were income barriers, where you have to keep your income low enough to show that you should get disability, but that is much below the poverty line. It hasn't been updated. It's just stupid things that we can advocate for our patients and for our family members and our loved ones, because I'm sure all of us know someone that's living with a disability.
Yes, the cap is $2,000. Folks, they are not allowed, individuals that receive SSI income are not allowed to have more than $2,000 in their bank account. And that hasn't been updated since, what did he say, 78 or something like that? It was the 70s.
Yeah.
And for cost of living increase alone, it should be increased to 10 grand. And there is a bill on the floor of, I think it was of the House, that had stalled. But to me, this is a nonpartisan am I saying the right words? Nonpartisan, bipartisan bill. Like everybody has somebody in their world that if we could elevate these levels, then God forbid something happens, but they would have money set aside. My Matthew would have money set aside for an emergency fund. Because I don't know about you, but $2,000 doesn't cover a lot nowadays. No. Also, I'm so glad you watched that episode. Of course you watched that episode. One of the things I love about you. Okay, but yes. Okay, so you had this lovely woman, and she is, and I followed her on Instagram, TBI Med SLP. Beautiful branding, by the way. I love the branding. And she mentored the daylights out of you. Blew your mind, figuratively speaking, on the financial fiscal access barriers, which I didn't actually know were part of this assessment. And then what is the test like? Because I got to tell you, sitting for the BCSS, I threw up and had diarrhea a couple of times before I even started the test. So, hi.
So the test you do get to take in the comfort of your own home. It's proctored via the internet, so you have your webcam on, and you prop your cell phone up so your cell phone also has a camera on you.
Oh.
And it's a smart proctoring, so it'll let you know, hey, you're looking away from the screen, or hey, I hear voices talking. But if you've ever taken a test in a room by yourself, of course you're gonna be like, okay, I'm talking to myself. So I kept having to tell the online proctor, I'm just talking to myself.
I always look away, but intense eye
look
contact.
away to think, right? I'm just looking away to think. I'm just trying to think. So then I would just have to think like this. So that was a little awkward because I graduated school before online learning became a thing. So I really have a lot of online learning or I guess online learning I've done through CEUs, but online testing not so much. So
yes,
that was
same, friend.
definitely an experiment. But I will tell you, it's 70 multiple choice questions and you have 2 hours to take it. But those multiple choice questions are cruel. It's the kind of questions where you have 5 choices and is it A and B or A and C or none of the above or all the above where you're just like, yeah.
Bah.
Yeah. So you really do need to study. And a lot of it is memorizing stats and memorizing neuroanatomy and memorizing different legislation. So it's a lot of memorization you have to do.
Nice. I don't know if you're the right person to ask this or not, but I've always wondered more about the thalamus. Just because, like, when you talk about neuroanatomy and physiology, the thalamus, it's just a fun word to say. So I always wondered, how much does the thalamus impact cognition, speech? What exactly does the thalamus do? Do you remember?
Yeah, so your thalamus is like the sensory relay point. So something starts through sensation and it gets processed through the thalamus. So if you've got problems processing in there, you're not going to be able to perceive and interpret information correctly. And so that can be one impact of the thalamus. The thalamus is part of the diencephalon, so it has a lot to do with memory. Yeah, and then sensory integration and memory. If you have a stroke in your thalamus, sometimes you can get thalamic pain syndrome where your body is having pain for no reason. It just keeps telling itself it's having pain when there's really no reason it should have pain. Yeah, the thalamus is interesting.
Huh. No wonder the thalamus stuck in my head. I always just like the way. I think I might need to get this book. What is the book? Can you just order the book off of the Amazon? Wait, sorry. Wow, South Carolina came out. I put the in front of the Amazon.
If you go to biusa.org, they have a store and they have the book that's like Brain Injury Foundations. So they have a web-based version or a paper version.
That's cool. Okay. 2025 reading literature, because right now I am rereading all of the Sookie Stackhouse vampire trash.
Oh, I've read all of those. I've read all of those. Yep.
Yeah, that's how I'm unwinding at night between vampire and werewolf and
Sometimes you need a little something escapism. You can't think about work stuff all the time, in my opinion.
You really can't. And I don't want my vampires to glitter to death. Let's be honest. I'm too old for that. Yes. All right. So I'm going to add this over here. What you can't see is I have a calendar that I use just to keep my notes on. Haven't changed it. It's May 2023, but I still write my notes on it because I haven't filled up my space. And then, yeah, this is my accommodation for myself. Yes.
There you go. Yeah, I think that the certified brain injury specialist is definitely relevant to someone who's working with peds because we know pediatrics get brain injuries.
Yes, they do.
I don't think this is an adults only type of certification, and especially just learning about. They even have portions that we have to learn about with IDEA and 504 plans and IEPs. Yes. That's all part of the test. It's not, you really have to know about peds and adults to be able to sit this test.
Oh, I love that. It is across the life continuum. Okay. Because I was worried, like when I did the BCSS, you can elect pediatrics or adults for like case studies. Like you get to pick which is great because we have to know the content across the life continuum, but the finer, there's a breakout for peds or adults. And so that's always a fear is if we know what it looks like in tiny human form, big human form, it's more than bigger boogers. There's a totally different pathophysiology here. So honestly, I knew it was it for me when I was in the hospital and I was doing a bedside eval because we didn't have access to instrumentals because we were 45 minutes away from from the big hospital that did instrumentals. And the nurse told me she had done oral care before. And I went in and I had to pull a mucus plug out of a patient's denture in order to even begin. And I was like, I can't do this because I almost threw up on him. So, yeah. Yep. Nope. Not. Ugh. Anywho, the TBI component. What I know this lovely woman. Was it Wendy? Was that her name?
Tracy.
Tracy. I knew it ended in a Y. Or wait, does she end in an I or a Y?
IE.
IE. Okay. IE. I was way wrong. But when Tracy was mentoring you about the TBI portion, how did that carry over to your work? What do you do and what can we as SLPs do with respect to the TBI component?
I think one of the biggest things that I learned with TEBIs was learning about mild TBI, also known as a concussion. And so I do at my outpatient clinic get referrals for patients that had a mild TBI or a concussion and they're having these persistent symptoms. And in my opinion, those are sometimes the hardest patients to work with because it's such an invisible disability. If someone has had a severe TBI and you can see maybe they might be in a wheelchair, they might have to use something to help them, or they might have obvious toxicity in their limbs, that can be something that people can really see and understand. But when people have a concussion, there's nothing on their body that tells you that they might be suffering from the issues from a mild concussion, which could be persistent headaches, it could be memory problems, it could be social emotional problems. And so when they have these problems, it can be really hard for the patients to even accept and understand what's going on because they don't see themselves as they're having trouble navigating this world now that they're having this new issue that it's not very obvious. So one of the big things about a concussion is it doesn't show up on brain imaging. So that can be really hard for, I think, even sometimes poorly informed practitioners in the world to say your imaging was fine, there should be nothing wrong with you. And I think understanding that just because their brain imaging is fine doesn't mean that they're fine, that if they meet the criteria for having a concussion, then they have a concussion. And we know that once you've had a concussion, you're 3 times more likely to have another brain injury. And we know from what's all happening in the NFL with the CTE that these repetitive concussions are really not good for people.
Yeah.
And it's not something that we can just write off.
Oof, triggering. When Goose is in 6th grade now, my oldest, when he was the summer between K and 1, so between kindergarten and first, he was in a summer program or daycare. It was essentially summer camp, so mommy could go to work. 2 second graders, and they weren't bullying, they were playing, but they weren't being watched. They were doing WWE wrestling moves, and they put Goose in a headlock and slammed his head to the ground twice. And I picked him up, and bless his little heart, it had just happened like seconds beforehand. And my bubby was crying. And Goose wasn't big as a minute. And bless, he's got the biggest head in the world as it comes. And I know because I pushed that thing out. And he's got the Dawson head. And so, like, legit, it was like 98% at birth. And I was like, I know, I was there. Thank God he was a little early. But I laugh now because otherwise I'll start crying again. But we immediately went to they gave me a resident. My Goose was a completely different child. I watched it happen to him. And the resident said, and I quote, boys play hard and you need to toughen up to me. Oh, ladies and gentlemen, I cannot say on air what I said to that resident. But let me tell you what, the hills flew out of my mouth faster than I have. I chewed him upside down, one side, the other. And then when I got done with the pulp that was left of this resident, because you don't mess with my Goose, or my bear. I requested the chief, and the chief came in and said, "Ma'am, you have a moderate level concussion," which I don't know what it means. But by then his left eye was having difficulty following and tracking. We ended up in the concussion clinic at MUSC, which was like 90 minutes away, and went back and forth for OT, and he had 6 months of OT for visual motor integration after that. And it was weeks of emotions up and down. We had to basically get rid of even Elmo's World, or no, what was he watching? Bear was watching Elmo's World that time. Sorry, ages. We had Elmo's World. Bubble Guppies. Bubble Guppies had to go on hold. It was horrific. And that was just boys playing rough. Y'all are missing the finger quotes here in the background, but hell, we do not play football because of this. We don't do contact sports because of this, because it was very scary. Yeah.
And I think that's why this certification is so important for adult or pediatric therapists, because anybody can get a concussion. You can get it from playing, you can get it from a car accident, you can get it from bicycle, you can get it from falling in the playground. You can unfortunately get it from abuse. That could be any of your kiddos that you work with or little ones.
Mm-hmm.
So it's not just, it's for teenagers that are driving or older adults who have falls. It's anybody can be dealing with it. And I think the more aware we are about all the range of issues you can have after a concussion, the better we can advocate for our patients,
Mm-hmm.
or our students, or the children we work with, our clients.
Yes. I mean, we're seeing that dog is shaking in agreement. Also, dog is still alive. I'm very excited because dog regularly tries to die, everybody. This last week, she scratched her cornea on we don't know what, and her eye was all gooped up and swollen, and she's hanging strong at her 13 and a half. We're hanging strong. Dog. But we're 2.5 years, almost 3 years into having the PFD code, and pediatricians still aren't aware nationwide on what this diagnosis is, because it's not something that they were taught in school. It's not something that everybody's familiar with. So the amount of advocacy and legwork that we have to do up front to raise awareness on that, I feel like the mild TBI and the concussion piece is equally as we have to do a better job of advocating. But then I tie it back to, but how much are students actually getting taught in the curriculum? Because are we actually getting this embedded within the academic sphere so that the students are prepped and ready for what they're seeing on the other side, like when they're practicing? I don't have an answer to that, just a question and a thought. Yeah.
Yeah, I feel like when I was taking my speech therapy in the schools course, I learned that you can have a 504 plan, but I learned that was for something like, that's if you have a hearing loss or you have something like ADHD. Like, no one had ever said, so if you have a brain injury or a concussion, that you could get a 504 plan.
Yes. I didn't, obviously, but like that was never told to me. Yes.
Mm-hmm. And so if you have a student or a child that has headaches and light sensitivity and blurred vision, and they have poor concentration in attention, and then behavioral problems, all from this mild TBI, which is what you can get from a mild TBI, they're going to struggle in school.
Yes, they will, or struggle at home. And
Right.
then if home falls apart, if we don't set our tiny humans and our adult humans up for success within their home, we then it's like throwing them to the wolves to expect them to go perform at a job. And children's job is to learn. I think their job is to play, but children's job is to learn. So school is their job, just like a career is our job. I had a cousin whose husband had a mild stroke, right hemisphere CVA, and he had to go back to work, and it was really hard. He's only a couple years older than me, and he struggled with executive functioning component, which is near and dear to my heart, because ADD, ADHD, executive functioning is my brain will get there. It just gets there differently in its own unique traversing through the woods and around a stream and around a valley, but we're going to get there. But post stroke, even though it's mild, when you're a 40, 50-year-old man and have to go back to work for your wife and your children, that's so what do you do? Like, what kind of therapies do you engage with for these kind of situations?
So I think that the most important thing is keeping it as patient-centered as possible. So if you have a patient that has had a stroke or a brain injury that's of working age, you can't just have them do crossword puzzles and word searches and connect the dots. There's no functional component to that. And yeah,
Mhm.
it might challenge their attention, but it doesn't challenge their attention in a way that's meaningful, that's going to carry over. So
Yes.
you really have to sit down with the patient and figure out, first of all, with brain injuries and with strokes, are they aware of their deficits? You have to start there. Do they have metacognition? Can they think about their thinking? Are they seeing how things are different? And once you can get them to start thinking about their thinking and being aware of their deficits, then you can start finding ways to apply it to where they're seeing issues in their everyday life.
I feel like that's the biggest difference between habilitation versus rehabilitation is that in the rehab world with our adults or like our older children, they're aware that something was there and they've lost it. But with our peds, this is for the most part baseline and they don't know different. And so when we're trying to get buy-in for care, for improvement, for accessing their environment through improved language or feeding, we have to get it's a different type of buy-in because they just yeah, it's a very different way to think about it. Metacognition, is this the word that you use? Thinking about their thinking?
About your thinking.
I like that.
Yeah. Well, and that's a big part of the executive functioning, right? If you're somebody that's a little scatterbrained and you know your brain takes longer to get there, it's not because you're stupid or you don't beat yourself up and say, I'm never going to think of it. You're just like, well, my brain thinks differently and I need to do things this way to get myself to work. And then that's fine. That's your metacognition telling you.
Sucheta, right?
Mhm,
Because
mhm.
yes, past president of Georgia, Sucheta has been on to talk about executive functioning disorder. And I have, in the middle of the night, this one thought that I keep going back to. I have accidentally overflowed the dishwasher, putting in hand soap as opposed to dishwasher soap a couple of times. So the first time was on accident. I didn't know there were different types of soap. I was a kid. But then after that, I was a broke college student. I was like, oh, soap. I'll just use like half as much soap. But no, it's very different types of soap. So now I genuinely want to know what is the ratio of Dawn concentrate that I can put in a dishwasher in a pinch without making it explode and come out the garbage disposal and the whole 9 yards. And when I told Suchetta this, and that is why you have ADD, my friend. There's gotta be a correct answer to that. So yeah.
Yeah.
Yes. Okay. Now, what are you have y'all? I love it. Y'all don't know the thought process that goes into keeping me on track in podcast. I always ask guests to come with questions. Send me the questions you want me to ask because I know we're going to go 14 different ways. And Cara went above and beyond and gave very specific, detailed questions, which I freaking love because that's not always the case. But there was one in here about statistics, and I am nerdy and I love good statistics. So, can you tell me your favorite statistics? Because that makes my heart oh so happy.
Well, and I tried to make sure I could think of some statistics that really had to do with pediatric and children, just so the listeners of this podcast feel like, okay, this is talking to me. But just to start off, we were talking about mild TBIs and concussions. 75% of all TBIs are a mild TBI. So it's very important about concussions. That's a huge proportion. There are 2.5, million or billion, 2.5 million people sustain a TBI annually, and it becomes the second most prevalent disability in the United States. That's a huge second most prevalent disability. The disability before it was depression.
Which I feel like there's an overlap. If you have a TBI, then you're
Mhm,
at increased risk, like you mentioned earlier, for a mental health disorder, and
mhm.
depression could be one. Oh,
Yeah,
this is sad. Yep.
yeah. So 13.5 million Americans are living with a brain injury right now, and that's 4.5% of the U.S. population. So out of 100 clients you might see, 4 of them are definitely going to have a brain injury. That's
Yes.
depending on
And
your
my
setting, it might be
caseload is
more.
my caseload's way higher than that, statistically speaking.
So the rates of TBIs in general have been increasing over the past between 2000 and 2010. So there's more TBIs happening. But what is also encouraging is less people are dying from TBIs.
It's like preemies. There's more preemies being born that are saved, but are we on the other side prepared to support them within the framework of early intervention and public schools? And I worry that not necessarily, because the more medically complex you are, the more likely you are to have peds dysphagia and require a feeding tube. And our schools are just not, at this moment, they're not all set for that. So is it car accidents? Is it sports injuries? What's causing the increase? Do we know yet? Or is it too many different factors
I
rolled
think
in?
it's too many different factors. If I was to guess, this is not an actual stat, but if I was to think about a reason why, I would think, first of all, it would probably have to do with our aging population, because we know a big proportion of brain injuries or acquired brain injuries could be strokes, or they could be falls in the elderly
Mhm.
population, right? So if we have an aging population that's more likely to have strokes or falls, then the brain injuries might increase, but it also might be increase in risky behavior, right? ATVs, motorbikes, motor vehicle collisions. It might be that too. Sports.
Mhm. I'm only laughing because we are so risk averse as a family because of what happened to Goose, but I really want to get a trampoline for the kids. And my husband is like, why? Of all of the things, should we get a trampoline? And I'm like, I really like jumping on trampolines. Now, pelvic floor therapy. Will I pee? 100 freaking percent. I will tinkle a little jumping on the trampoline, but I think it would be fun. And it's like a rite of passage for kids to have a little trampoline. But as he pointed out, I didn't want a little one, and he's worried about head injuries. And I'm like, yeah, there's a reason God had you and I record today, because he was like, let's look at the statistical. This is my engineering husband. Let's look at the statistical safety of a trampoline. Y'all, because of Cara, I am no longer going to make a solid argument for a trampoline for the backyard. Yeah, but you're right.
Yeah, yeah. And it's, I think there's plenty of things that we can do to keep children safe from things like bicycle accidents, like wearing a helmet, right? Doesn't mean you. That's why I freak out anytime I'm like in my neighborhood or driving around and I see kids without helmets on. I'm like, put the helmet on.
Yes.
Brain injury makes me go crazy.
We had a little girl in our subdivision back in South Carolina whose mom just let her tear up the subdivision. We were right downtown. So that's a safety issue, anyways, because we were in the state capital. But she got hit by a car. And luckily, she was safe. Technically, she hit the car. She ran the stop sign, but she was 7 running the streets, went straight down a hill and T-boned the car and bounced off. And I happened to be in the front yard and helped hold her down while we were waiting on 911 to get. I have never been so angry in my life, but like, where's our parents? I don't know if they ever found the parents. Helmets are important. She was not wearing one.
Yeah, helmets are how we don't call it shaken baby syndrome anymore, but unfortunately, that non-accidental trauma is the cause of 80% of deaths from head trauma for children under the age of 2. That's
Ay.
yeah. That's a sad one. And then 67% of children with a TBI, it's due to physical abuse,
Mm.
which is sad to think about, but that might be a child you encounter on your caseload. You can't, just because it's bad to think about doesn't mean you can ignore it.
Yeah.
Yeah.
Also, and y'all, it can be very challenging when you're working with a little one that has had this as their PMH, past medical history, to access medical records. For circumstances like that, getting the medical records is so challenging because they're often sealed in court cases, or they go into the foster system and the new foster parent might not be able to access originals. So it's I have one little guy that I'm working with, and it has been very difficult because the caregivers are trying to be the best historians they can. However, they don't understand the extent of the child's brain injury and they don't have access to, nor does the pediatrician. And the pediatrician, her and I spoke extensively. We've tried to advocate and we can't get through. So,
Yeah.
yeah. Yeah.
Yeah.
Mm.
Yeah. Yeah, a lot of the brain injury stuff can be pretty heavy, but then looking at from that rehabilitative side, we can help people recover from that, or we can habilitative
Yes.
side, we can help them go on to live functional lives if we help them navigate through. Here's some different legal things that might help you. Here's some different avenues to look into. Here's some different ways to advocate for yourself.
Yes. Do you do anything with assistive tech or AAC, or do you get to pull that into your outpatient setting?
Yeah, we do.
Oh, I love that. Have not done a lot with Tobii Dynavox yet, not for lack of trying. We've just had the position in our geographic area has changed 3 times in the 18 months that I've been here. So it's been a little hard to peg people down, but fingers crossed we will get there. But that having those tools easily accessible and in the clinic has been incredibly helpful for me to be able to pull out a different tech to try with the patients. So,
hmm
yeah. Just
Yeah,
thinking.
I've been able to use eye gaze devices for a young woman who had an acquired brain injury, and
Mhm.
just opening up that world can mean so much.
Yes, it can. What about co-treatments? Has this process, the CBI certification, as well as working with TBI patients, do you find yourself doing more co-treatments with OT or PT, or doing more advocacy with like interprofessional practice?
In the outpatient setting, it can be hard to do co-treatment sometimes, and sometimes the patients don't always want it because they're like, I want my hour of speech, I want my hour of OT. We do a ton of collaboration. So if we're working on return to work between speech and OT, we're going to try and figure out what are the skills we need to address, what are things we can do together, what can we make sure that we're touching on the same things. And so I'm fortunate to work in a clinic that is very collaborative,
Love
and all
that.
the therapists I work with have very similar mindsets to myself, that I never feel like patients are not getting what they need where I work. I feel like this is the best place for you to go. Um,
Love that.
yes, because like I said before, if you're not providing care that's patient centered and you're just treating the diagnosis and not the person, I can't work with you. I don't know. Like, I just can't. I won't be able to handle it. I've been told to before that I'm a little too passionate, but I'm sorry. I have professional integrity, and if
Yeah.
I'm going to work
No, but you're
professionally,
gonna.
let's do it
Yes,
for the patient.
that's. Y'all, I told you she was fiery and passionate, and I loved her. Yes, this is why. If you're gonna get a righteous anger, then you might as well get a righteous anger to do the right thing and to see it through and for it to be done well. And that's down to our documentation. I hate writing reports. I hate writing reports. And the complexity of some evals are just literally exhausting. But our documentation justifies treatment. Our documentation justifies intervention. And insurance companies, especially private insurance, will come back and look at it and say, is it enough? Is this right? Does this meet muster? And each state has different guidelines according to their CMS manual. So God help you if you learn it in one state, Michelle Linwood Dawson, and then you move to another state, Michelle Linwood Dawson, you're going to have to learn a whole new set of rules. And that's huzzah, we're going to get there. Yes.
Yeah,
No.
it's a lot to be able to. Like I said, there's no setting that's easier than harder than another, because I've done acute care, which is not so much justifying what I'm doing as much as I'm just running around doing everything diagnostic wise.
Yep.
Outpatient can be just as challenging because you might have the same patient and you're constantly trying to justify what you're doing for them and trying to come up with a creative plan that's going to meet their needs so they can get the best outcome.
Yeah. Yes.
It's challenging.
Okay. Ooh, dog is groaning in support down there with her little bitty self. If somebody is listening and they want to take on working, if they're not specifically working with individuals that have traumatic brain injuries, is there a course or a resource that you would recommend that they pursue or look into?
So if they're not particularly working with traumatic brain injuries, but they want to learn more about it, I think maybe starting with just general your state organization's convention is always a great place to start.
Yes, it is. Yes, it is.
That's because, if you go to a general convention, that can be a great way to dabble in things and topics you haven't touched on before, and kind of network with some people in your area or people nationally that are working in it. And you might find that you meet someone or you listen to someone that's very inspiring, that's opening the door for you.
Mm-hmm.
So I'm a big
Yes.
that.
Love that advice. Okay. And if somebody wants to pursue the certified brain injury specialist, what was the website that you recommended?
It's www.biausa.org. But if you just search CBIS on Google, it should come up.
Beautiful. Okay. And then is there any, before we go into the goods of getting your contact information and your favorite donation spot, is there any final thoughts that you have that was just like your aha, this was the right thing for me moment?
That's a hard question.
I know.
I hope that people understand that if you're a speech therapist, it doesn't matter what setting you work in, you're going to work with someone with a brain injury. I think that kind of was the aha for me as I went through this training is, oh, this is not just outpatient. This is not just acute care. This is all walks of life and all settings.
That's how I feel about feeding disorders. No matter where you are in the peds world, it will find you because 1 in 5 under the age of 5. Like that's huge.
Mm-hmm.
Yeah. Okay. Thank you. Oh my gosh. Thank you. I'm trying to be respectful of our time because I know that I will continue to babble away with you and go over. But if somebody's listening and they want to learn from you or they have a question or a follow-up question, how can they reach you?
Well, you can reach me by email. It's kajoneslp@gmail.com. That's K as in Kara, A as in Ann, Jones, SLP. But you can also follow me on Instagram, Speech Lady Kara.
I love that. Okay, wait. Is your middle name actually Ann?
Yes.
With an E or 2 N's?
ANN. Yep.
That's my little sister's name, Jennifer Ann. But my dad called her Squat and Squab, which is a baby dove, and I couldn't say Squab, so I called her Squat. And then Bear couldn't say Squat, so he called her Aunt Twat, and it stuck. So now my sister is henceforth Aunt Twat for the rest of her life.
Oh no.
Amazing. Okay, so Speech Lady Kara, not Aunt Twat, and Speech Lady Kara, thank you so much for coming on. Wait, your favorite, if somebody wants to donate, if they have a spot for love money, where can they send love money to?
So you can help out my friend Tracy, her 501c3 brain injury education organization. You can go to tbimedslp.com. And you can also follow them on Instagram, tbimedslp.
Amazing. Oh my goodness. Okay, thank you for being you and just being passionate. You're never too passionate. It's always the perfect amount. I love it. And just genuinely shining a light. Our world is hard and you make it easier. So thank you.
Thank you for having me.
Yay. Absolutely. Okay, hold on 1 second. Folks, oh, I always forget this part. Check us out, First Bite Podcast on Instagram and on the Land of Facebooks. We love it if you message us a speaker that you're interested in having on or a topic that we have or have not covered if you want us to cover it again, but just send us a message. But everybody, thank you for joining us.
Thank you for joining us for today's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to reflect on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time.
Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.